Amebic liver abscess. How do you actually diagnose it? Let's talk about a clinical problem that can be surprisingly difficult. A patient has a liver abscess. How do we determine whether this is a typical pyogenic abscess or an amoebic liver abscess caused by Entamoeba histolytica? The first important point is this: imaging alone cannot reliably distinguish an amoebic liver abscess from a pyogenic liver abscess. According to the IDSA and ASM guidance, when evaluating a space-occupying liver lesion, we need to consider pyogenic infection, Entamoeba histolytica, and, in the appropriate epidemiologic setting, Echinococcus. And do not rely too heavily on whether the lesion is single, multiple, or located in the right lobe. Those features overlap significantly between different etiologies. So what makes you suspect an amoebic liver abscess? Start with the epidemiology. Think about patients who live in, immigrated from, or recently traveled to an area where Entamoeba histolytica is endemic. The classic presentation is relatively acute, usually developing over approximately 2 to 4 weeks, with fever and a constant dull pain in the right upper quadrant or epigastrium. Patients may have very focal hepatic tenderness. Interestingly, gastrointestinal symptoms do not have to be prominent. You can absolutely have an amoebic liver abscess without obvious active dysentery. And this brings us to an important diagnostic mistake. Do not rely on the stool examination. Fewer than half of patients with amoebic liver abscess have detectable intestinal parasites at the time of presentation. Stool microscopy or stool antigen testing therefore cannot reliably exclude the diagnosis. So what test should you order? The cornerstone is serum antibody testing against Entamoeba histolytica. Serology is highly sensitive and highly specific for amoebic liver abscess, with reported sensitivities generally above 90%. However, there are two important caveats. First, during approximately the first 7 to 10 days of illness, serology can still be negative. So if your clinical suspicion is high and the initial serology is negative, repeat it. Second, antibodies may remain positive from previous exposure. In someone from an endemic region, a positive antibody does not automatically prove that the current liver lesion is caused by amoebiasis. Now, there is another interesting option: circulating amoebic antigen detection. The Gao-Galenac-lectin antigen can be detected in serum during active disease, and unlike antibodies, may disappear after treatment. That means antigen testing is potentially particularly useful before metronidazole is started. What about aspiration? Here is another important clinical point. You do not necessarily need to aspirate every suspected amoebic liver abscess simply to establish the diagnosis. If the epidemiology, clinical presentation, imaging, and serology fit together, the diagnosis can often be made non-invasively. But if aspiration is performed, for example, because the diagnosis remains uncertain, the aspirated material can be tested for Entamoeba histolytica. And this is where molecular diagnostics become extremely powerful. PCR, or quantitative PCR, performed directly on abscess material is probably the most accurate confirmatory test available, with reported sensitivity and specificity approaching the high 90% range. Serum qPCR for Entamoeba histolytica DNA is also emerging as a fascinating non-invasive diagnostic option. Early studies suggest that it may help identify active infection and possibly distinguish active disease from previous exposure. So my practical approach is this: you have a patient with a liver abscess. First, evaluate the epidemiology. Was there travel, immigration, or residence in an endemic area? Second, review the imaging. But remember that imaging identifies the abscess. It does not reliably establish the organism. Third, obtain Entamoeba histolytica serology. If it is negative very early in the disease and your suspicion remains high, repeat it. Consider serum antigen testing before treatment when available. Do not exclude amoebiasis because the stool examination is negative. And if aspiration becomes necessary, Send the abscess material not only for aerobic and anaerobic bacterial cultures, but when amoebiasis is in the differential, for amebic antigen testing and preferably PCR. The key message is simple. Amebic liver abscess is fundamentally a clinical pathologic and epidemiologic diagnosis. Imaging finds the lesion. Epidemiology raises the suspicion. Serology usually confirms it. And PCR of the abscess provides the strongest microbiologic confirmation when the diagnosis remains uncertain. This is Dr. Ganoni. And remember, when you see a liver abscess, don't just ask, what does the CT look like? Ask the more important question, why does this patient have a liver abscess?